It's great to be back and talk to you about one of my favorite topic. So what my plan is to review some of the most eye-catching abstracts from the liver meeting that are pertinent to patients with cirrhosis and portal hypertension. And I've got a ton of slides for you to review, but I think my key interest here is to look at the clinical background for each of these studies, pull out the most important tidbits that would apply for you in the clinic when you're seeing patients. In terms of conflicts of interest, on an advisory board for one of the drugs that we'll be discussing. So the first few abstracts are pertinent to patients with hepatic encephalopathy, and the coolest one comes from the group in Virginia Commonwealth University. This is Dr. Jaz Bajaj, whose name is synonymous with hepatic encephalopathy research, and what he is trying to champion is the idea that our microbiome is playing a critical role in the development and progression of hepatic encephalopathy. As we'll see throughout these abstracts, obviously ammonia plays a key role in the development of hepatic encephalopathy, but one of the things that causes that ammonia to be particularly neurotoxic, and one of the reasons why ammonia levels don't correlate with symptoms, is because inflammatory burden in your patient's blood is what determines how toxic that ammonia is. So he explored the role of periodontal therapy in the burden of inflammation in patients with cirrhosis. So cirrhosis is a systemic inflammatory condition vis-a-vis translocation of bacteria and bacterial wall products from the gut. Portal hypertension causes gut barrier disruption and therefore translocation of the contents of our small and large intestine systemically through portal hypertension. So obviously the bugs are coming from the GI tract, but there's more to the GI tract than just your intestine. And what he hypothesized is that the microbiome of our mouths may be contributing. And you may recall the teeth of many of your patients with cirrhosis. Dentition is an underlooked problem for this population. And we also have a way of fixing that by referring them to a dentist. So what he did is he enrolled 20 cirrhotic patients in aged match healthy controls, each of whom had mild to moderate generalized chronic periodontitis. If it was so severe that they needed to have teeth pulled, they were excluded from the study. And what he did is he collected baseline information about their inflammatory burden and their MELD scores. And what we see in this poster, the key points here are that before therapy, there was an elevated inflammatory burden in patients with cirrhosis, and after therapy, not only did you see a significant decrease in the white blood count, an obvious indicator of inflammation, but also endotoxin, that is cell wall products from bacteria, and TNF. So the actual inflammatory cascade triggered by bacteria has been decreased significantly, statistically significantly, for patients with cirrhosis. That was also true for patients without cirrhosis, implying that they were doing something that is generalizable. But obviously for people without cirrhosis, the overall impact on inflammatory burden vis-a-vis white blood count, endotoxin wasn't changed. So does this change one's risk for hepatic encephalopathy? Obviously that's something that he'll explore beyond these preliminary data, but it is something to consider that this may potentially benefit our patients. So moving forward, Dr. Bajaj also had a pretty cool study. This is a picture of somebody meditating. And it brings up a couple of things about the broader syndrome of hepatic encephalopathy. Obviously, if they're showing up in a coma, meditation is not going to help. But for people with grade 1 encephalopathy, to some degree, it's how we cope with those deficits that influences whether it will change our impact on our daily lives or our family members. And when you have a rapidly fluctuating condition like hepatic encephalopathy, not only does it stress you out, it stresses out your caregivers. So taking care of, living with a patient with hepatic encephalopathy creates a profound burden. How are we going to treat that? There might be pills that help for that. But beyond pills, it's worth thinking outside the box. And so what this group did is they enrolled people in a prospective trial of mindfulness meditation, or Qigong meditation. And essentially this is what the Dalai Lama advocates, a process of sitting in a quiet room and thinking about the conflicts that you have in life, internalizing those conflicts and viewing everyone through a lens of loving kindness, trying to see the best in people and work towards conflict resolution. So he enrolled people who were cirrhotic outpatients who had, at baseline, defined by questionnaires, mild depression, and an adult caregiver, and there was no pre-specified limits on who that caregiver was. And what they did is they assessed patient-reported outcomes for both the patients and the caregivers, and they assessed cognitive function in the patients with cirrhosis. So the trial looked like this. They enrolled everybody, and then they had 4 hour-long sessions, week 2, 3, 4, 5, where they were trained by someone in the art of meditation, told to go home and practice this, and they had to do their homework and turn it in to say in a logbook that they had been doing meditation at home. And at the end of the study, like at the beginning of the study, we assessed all their patient-reported outcomes. And what we found is, of course, meditation doesn't change MELD score. Meditation does not change the prevalence of cognitive dysfunction or these PHES scores at the bottom. But what it does do is it reduces the burden of depression, inducing remission in a substantial proportion of people with diagnoses of depression. It improves their overall health-related quality of life. The questionnaire is the SIP. It improves their sleep overall, too. This is also true for the caregivers who had a substantial decrease or statistically significant decrease in their self-reported burden of being a caregiver and improved sleep. So, meditation does not improve encephalopathy, of course, but it improves a host of patient-reported outcomes, i.e. things that matter to our patients get better. And in conclusion, why not? The only cost is time. So the standard of care for the management of hepatic encephalopathy is, at a minimum, lactulose, particularly when they've had an episode of overt encephalopathy, rifaximin, and a high-protein diet. But there are other ways to think about the management of acute encephalopathy, which get at the pathogenesis of hepatic encephalopathy. And I'll talk about this trial of OCR-002, ornithine phenylacetate, in this context. So this is a little cartoon I once drew that gets at where ammonia comes from and how it leads to encephalopathy. One, ammonia is the product of protein metabolism. And the #1 contributor of ammonia in the blood is the metabolism of the amino acid glutamine. And like I said before, inflammation influences the symptoms from hyperammonemia. So there's this new drug, ornithine phenylacetate, and it has 2 components. One, ornithine will combine with glutamate and ammonia to form glutamine. So it's taking the ammonia out of the equation by forming glutamine. But before any part of your body, like the kidney, can take that glutamine and make more ammonia, which is one of the main problems with excesses of glutamine in patients with cirrhosis, phenylacetate comes into the mix and turns it into a water-soluble molecule called pagin, which the kidney then excretes. This is a way of scavenging ammonia and glutamine. 2 hits on the pathogenesis of encephalopathy. So they enrolled in this multi-center trial patients with grade 2 encephalopathy or greater. Because their mechanism of action is excretion through the kidney, you can't be on dialysis. You can't, and they wanted to have people with a life expectancy greater than 12. And what they did is they chose to enroll people and then give them the study drug after 12 hours. So, in my experience, probably in your experience, when you come in with acute hepatic encephalopathy, you get lactulose, you get better, and then if the trigger for your encephalopathy was infection, you stay in the hospital for a couple of days. But if your only trigger is non-compliance, you can turn that person around pretty quickly. So all of a sudden, you start to see in the study design that this is a relatively unique population, a population which is not responding, perhaps, to the standard of care. Or perhaps they did, and they're still somewhat encephalopathic. As I'll show you, they were enrolling people with grade 2 encephalopathy. So they randomized people to placebo plus standard of care, lactulose and rifaximin, your choice. For a 5-day infusion, they titrated the infusion dose to how severe the injury was, and they were looking for a clinically meaningful decrease, i.e. coma to grade 2 or grade 2 to grade 1. So everyone had to have at least asterixis and clinically significant improvement, no more asterixis, no more disorientation. And of course, if they got them all the way better, fantastic. So these were people that were typically child B and C with a high median MELD score. And for the most part, these are grade 2 encephalopathics, okay, so mild disorientation. Their triggers were essentially unknown, but the identifiable ones were bacterial infection and poor compliance of lactulose. And what they found, and I'll editorialize while we're going through this, is that the drug was not significantly associated with time to resolution of symptoms. So just if you take a step back and look at the inclusion criteria, you had to have an ammonia level greater than the upper limit of normal per your lab. So in that 12-hour period, you're getting an ammonia level. It says that it's high. If this drug is scavenging ammonia, then that's the only way it's going to work if you have a lot of ammonia causing your symptoms. So here we are. The drug didn't work. So what they did is they looked at all of the samples that were submitted and said, well, it turns out that your lab was wrong in 30 patients. In 30 patients, your lab said that ammonia was high when in fact it was normal. And if you look at just the people who had normal ammonia, well, then we had a statistically significant decrease in the time to resolution of symptoms. There were no adverse events. And so basically, this is a new safe kit on the block for inpatient management of hepatic encephalopathy. Measurement of ammonia is notoriously tricky. You need to have a very clear protocol if you're going to do that. In fact, it's not really clear that it matters for most patients because you can have overt encephalopathy without an elevated ammonia level, as did many of these patients. So you have to think about what kind of a patient needs a 5-day infusion for hepatic encephalopathy, and I'm not sure it's someone with grade 2 encephalopathy, but certainly someone that can't take an oral medication like lactulose, certainly someone that you're worried about in the intensive care unit with a high-grade encephalopathy. So pivoting, there was a study out of Denmark on the adverse effects associated with PPIs. So PPIs have been associated with a host of problems in the epidemiology literature, including infections in cirrhotic patients, readmissions in cirrhotic patients, hepatic encephalopathy, and SBP. Why are PPIs associated with infections? In part, we think maybe it causes some bacterial overgrowth. There's also a proton pump on neutrophils, and it does cause some degree of immune paralysis in vitro. So if you wave your hands long enough, you do have a good reason to support the adverse effects associated with PPIs. But there's problems with all of these database linkages. You're giving PPIs to sick people in the first place, so those people may be more likely to generate outcomes. So if you want to have a great study from an administrative database, you turn to Scandinavia, where they have data on every one of their patients. They looked at them from 95 to 2014. This group does all their studies on alcoholic cirrhotics, so they made it count twice, and they made sure they had patients with at least 30 days of follow-up, and they looked at the development of SBP, pneumonia, and infectious colitis, aka mainly C. diff. After they excluded people with cancer and other causes of liver disease, they ended up with 20,000 people, and they performed propensity matching to try to recapitulate the terms of a randomized controlled trial so that people were relatively balanced in terms of their demographics, whether they received a PPI or not. They had 10,000 people in this propensity score matched population. Subtle differences including that there were more people in the PPI group that received alcohol, and there were more people who were working in the group who did not receive a PPI even after matching. And what they found is that in this cohort, in the unmatched cohort, PPIs were associated with a statistically significant decrease in the development of SPP. Take that for what it's worth. But when you match the cohort, there was no significant difference. Again, no difference when you match the cohort for the development of pneumonia, no difference when you match the cohort for PPI use for the development of C. diff and other forms of infectious colitis. Which gets at, we should not be giving PPIs to everybody willy-nilly. But if you have a person who had a recent ulcer or severe quality of life limiting GERD who happens to have cirrhosis, then that is a person who benefits from PPIs. But if in your mind you can get that person off of a PPI without making their life worse, then you should do it. And you shouldn't feel bad when you feel like your hands are tied and you keep them on PPI. So shifting to a study of a drug designed to increase platelet counts, this is getting at patients who have thrombocytopenia. Many of our patients with cirrhosis do. Sometimes need to have invasive procedures, and you find yourself on the phone late on a Friday arguing with an interventional radiologist or pulmonologist that it is in fact safe for this patient who's in extremis to have their paracentesis or thoracentesis. That person gets a platelet transfusion, and for the most part it's safe, but every now and then that platelet transfusion is associated with severe adverse events, including but not limited to trolley, TACO, and all the other acronyms that pulmonologists have developed, and it's associated with costs. Those platelets could be used for other patients that need them, and if there was a way to supplant the need for platelet transfusion to prevent bleeding and cool everybody's jets about doing invasive procedures in patients with cirrhosis, then that's a win-win situation. So thrombocytopenia is common in liver disease, and I just want to review very briefly where this comes from. This is a cartoon I drew once upon a time, and I'm going to highlight a couple of things. Platelets are low in cirrhosis. In fact, the platelet count is the most predictive lab test to help us predict who among our patients with liver disease has cirrhosis. And there's a few reasons for that. One, portal hypertension induces splenic sequestration of platelets. Two, gut translocation of bacteria induces a nonspecific immune response which leads to platelet antibodies that destroy our patients' platelets. And three, the hormone that generates platelets in the first place, thrombopoietin, is made by the liver. And so as our liver's function decreases, so too does the production of thrombopoietin. And in vitro, prior studies have found that a platelet count less than 60 is associated with bleeding. Now, if your patient without cirrhosis develops thrombocytopenia, they're not going to bleed at a platelet count of 60. So what's unique about cirrhosis is that the liver function also affects the coagulation cascade. In general, it's balanced because they're also making less protein CNS. But at a certain point, their ability to produce thrombin, their ability to coagulate becomes hampered because the platelet is itself a biologically active catalyst for the production of thrombin. When your platelet count is 40 or lower, you're much less likely to make thrombin. And the platelet is affecting the coagulation protein cascade. So in vitro, 60 was a good tipping point, but of course there's a lot of uncertainty around that. So there have been prior drugs that have looked at replacing thrombopoietin through thrombopoietin agonism. One of them was Eltrombopag, and this was published in the New England Journal a few years ago by my original mentor. And what they found was that you were able to increase the platelet count through giving thrombopoietin. You did reduce bleeding episodes. You did reduce the need for platelet transfusions, but several people developed portal vein thrombosis, and in some cases this was a significant life-changing event. Many of these patients had very high platelet counts at the time of that thrombosis. Many of these patients had hepatocellular carcinoma. So in view of these safety concerns, Eltrombopag hasn't really penetrated into the market in this situation. So avatrombopag launched 2 simultaneous randomized controlled trials designed to look at a follow-on thrombopoietin agonist. In this study, the notable differences are these. 1, the treatment was only 5 days, and it was stopped before the time of the invasive procedure. 2, they looked at people who had low baseline platelet counts, less than 40, and high baseline platelet counts, 40 to 50. And they adjusted the dose of Eltrombopag accordingly. The efficacy endpoint is obvious. They're looking for the proportion of people not needing a platelet transfusion or any form of bleeding rescue treatment, be it any kind of treatment or interventional therapy. And secondary efficacy endpoints looking at just achieving a target platelet count. Looking at adverse events, of course, they are actively screening people for portal vein thrombosis. What you see here are that most of these people are a little more compensated than in our HE trial, mean MELD score 11, most of them child A. Proportion of patients who did not need a platelet transfusion was significantly higher in both of these cohorts when they received Eltrombopag compared to placebo. And the proportion of patients who achieved the target platelet count of 50 or greater was significantly higher. If you look at the kinetics of these platelet changes, you can see that at the day of the procedure, they had their peak platelet count on average 80, a little bit lower than in prior trials, and this would taper back to baseline by the end of the month. There was only 1 person who developed a partial portal vein thrombosis, and fewer than in the Eltrombopag studies, but obviously something that needs to be followed moving forward. So obviously there's a persistent unmet need for thrombocytopenic patients requiring a procedure to avoid transfusion. And the question is whether this is cost effective and how that would change our practice. Those data are pending. So my last study is a follow-on about viral hepatitis. So we're treating everybody. We're curing virtually everybody except for small groups that have a high rate of failure, and those include people with decompensated cirrhosis. So one of the other things that we don't often talk about when treating patients with decompensated cirrhosis is that their liver function could get better, and sometimes it does not. And if your liver function gets better, but you maintain your ascites, this is a pretty bad place to be. Because if you have a low MELD score, but you still have ascites or encephalopathy, then you're not going to have a MELD score that would garner you a liver transplant, but you're living the life of somebody with decompensated cirrhosis, and your liver disease is stable moving forward. We call that Meld Purgatory. So who in our patients with decompensated cirrhosis is going to benefit from DAA therapy? And what this study did, and I was involved with the analysis, is that they included all of the data from the SOLAR trial and Astral 4. So that is when we took Harvoni and looked at what happened to patients with decompensated cirrhosis, and Astral 4 was epiclusa in patients with decompensated cirrhosis, published in the New England Journal last year. And this other one with a long acronym was a wild fantasy where you could give people Harvoni and reduce their portal pressure, but they were all decompensated. So if you take everybody with decompensated cirrhosis who got a sofosbuvir-containing regimen and looked at their data for 12 to 24 weeks after treatment. So the primary outcome was sustained child A cirrhosis. This is the win. You have taken someone with a decompensation and returned them back to the state from whence they came. And the secondary outcome here is Meld Purgatory, including, of course, all modeling looking at death or transplantation. So the overall SVR rate in this group, 85%, mean follow-up under a year, 17 transplants, 35 deaths. Of the patients who developed SVR, child A was achieved in 36, so 1 in 3 patients returning to a compensated state when they had child B to begin with, and only 1 in 8 when they had child C. So these are good numbers to quote for your patients. SVR was associated with a sustained child class A and also a transplant or death. This was highly protective of the need for transplantation or death. So if we wanted to look at a baseline risk score to tell us who among our patients is likely to benefit, likely to develop child A cirrhosis, then the answer are these. BMI less than 25, no encephalopathy, no ascites, an ALT that's elevated, and an albumin that's elevated, okay? So you had a relatively compensated albumin and you hadn't developed encephalopathy. As you start to rack up points in this scheme, you start to develop a high risk of, you develop a very high chance of developing child A cirrhosis with relatively tight confidence intervals until you get very high up. So the ratio for achieving child A is highest for the groups with the highest BE-AAA scores. 32% of patients with SVR12 became compensated when they had child B cirrhosis after DAA therapy. And a 5-point score that takes into account whether your patient has a normal BMI, a lack of encephalopathy, a lack of ascites, a high ALT, and a relatively normal albumin will predict which of our patients with a decompensation will become child Pu class A with treatment. Thank you.